Hello and welcome. This is the 50th Cervical Spine Research Society Annual Meeting, and we're very fortunate to have a great group for case discussions. First of all, I want to thank our annual meeting committee. They did a fantastic job. We hope to catch everyone up in San Diego starting on Wednesday with our in-person visit. I'd like to start today's session. We're very fortunate to have a great group. Heiko Kohler from President of European Cervical Spine Society. We have Dan Rowe, who is a past president of Cervical Spine Research Society, and we're very fortunate to have Dr. Young Q. I'm excited to hear you guys and take it away.
Hi, I'd like to thank Heiko Kohler and the CSRS for participating in this virtual ICL. I'm Themistocles Protopsaltis from NYU, and I'll be discussing specific cervical scoliosis surgical cases. These are my disclosures. The first case is a cervical thoracic scoliosis, 21-year-old male from Morocco with a history of neurofibromatosis. He had progressive paralysis over a month. He underwent a laminectomy from C7 to T2 by neurosurgeons at an outside hospital for a neurofibroma that was causing cord compression. He was then transferred to rehab and then presented to us with pain and cervical thoracic kyphoscoliosis. He had significant weakness in his lower extremities and was hyperreflexic, but he was able to rise from the wheelchair with some moderate assistance and take some spastic steps. These are his cervical x-rays, flexion extension, as well as full spine x-rays. And a CT scan demonstrated a significant kyphoscoliosis centered at the cervical thoracic junction. 3D reconstructions of the deformity show fairly complex deformity centered between C7 and T4, where the resection was performed. You can see the MRI demonstrating complete resolution of the cord compression, but a tortuous course to the spine, the spinal canal, and the spinal cord itself. So he underwent a C3 to T6 posterior spine fusion instrumentation with correction of his kyphoscoliosis. And over the course of a year, his neurologic status improved. He went from being wheelchair bound to ambulating independently. However, 17 months post-op, he heard a pop in his neck, had increased neck pain and recurrence of his deformity, and a progressive decline in his ability to ambulate and his balance. You can see the x-rays demonstrating fracture of his rods, which were 4.0 titanium alloy transition rods going to 5.5 rods. These were bent at the time of surgery. CT scan demonstrated failure of fusion both in the posterior column and the anterior column. And so he was revised to a posterior-based VCR of T1, T2, and T3 with anterior column support from C7 to T4 using a mesh cage. You can see the mesh cage there located spanning C7 to T4. And this time we used 3.5 to 5.5 titanium alloy patient-specific custom rods. 5 months post-op, he had another pop in his back and recurrence of the deformity. And the CT scan demonstrated failure of healing at the caudal extent of the mesh cage in the anterior column. So he was revised a second time from C2 to T11 with a fusion that included revision of the anterior arthrodesis, laying more bone graft and decorticating more in the anterior column, as well as using this time cobalt chrome patient-specific custom rods and an additional satellite rod connecting a C2 laminar screw to laminar screws at T4 and T5, and then connecting that rod to the one of the rods using rod connectors. 6 weeks post-op, you can see restoration of alignment, both sagittally and coronally, and he's back to independent ambulation without assistive devices. And at 1 year, we got a CT scan just to ensure that there was good healing at the caudal extent, which there was. 1 year post-op, he was doing very well, independently ambulating with no neck pain, and had a job as a software engineer. The next case is a partially flexible chin-on-chest deformity with combined coronal and sagittal malalignment. 57-year-old male with a remote history of cervical trauma, was neglected due to social challenges in his life. He has a past medical history of hypertension, hyperlipidemia, and substance abuse, but he was completely off all illicit substances and had very good family support. He had a partially flexible chin-on-chest deformity with a coronal head tilt to the right, neurovascularly intact. You can see his x-rays demonstrating that chin-on-chest deformity in the coronal malalignment. Clinically, his chin-brow vertical angle was about 30 degrees. With a lateral x-ray with the patient holding up his chin with his hand, you can see he still had a 30-degree kyphosis from C2 to C7 and an increased CSVA of 7.5 centimeters. T1 slope was increased slightly to 20 degrees, but did not imply that he had significant thoracolumbar deformity. And flexion extension x-rays demonstrated no ability to actually extend the neck whatsoever and create any lordosis. CT scan demonstrated a mid-cervical kyphosis as well as kind of a sweeping upper thoracic kyphosis, but with some bridging osteophytes. And the coronal deformity was largely due to asymmetric disc collapse and right-sided facet arthropathy of the facet joints. Looking at the x-ray, there was a focal kyphosis of 75 degrees and a C2 to C7 of 85, but in the CT scanner supine, that focal kyphosis was about 65 and the C2 to C7 kyphosis decreased to 35. So it's somewhat partially flexible. So the surgery was anterior and posterior. In the anterior stage, we put them in traction. We did ACDFs at C3, 4, C4, 5, and C6, 7, and then complete oncovertebral resections at 4, 5, and 6, 7, and then also release of the sternocleidomastoid. Posteriorly, he had a C2 to T10, posterior fusion with grade 2 Ponti facet resections. You can see clinical photo demonstrating the tight sternocleidomastoid. So I released the sternal portion of the sternocleidomastoid and maintained the clavicular portion. That helps significantly with when there's a flexion contracture. And here you can see a schematic depiction of the grade 4 ankle vertebral resection and the posterior grade 2 osteotomy. This is a clinical photograph of the anterior approach, demonstrating the divergent Castor pins to help with the kyphosis correction. And a pen field is used to protect the uncovertebral joint, to protect the vertebral artery and resect the uncovertebral joint using the burr. It's important to make sure that you're medial to the vertebral artery when doing this, and look for the CT scan. If there's voluminous bone in the uncovertebral joint, sometimes that bone can extend lateral to the vertebral artery. In some cases, I expose the vertebral artery from transverse process to transverse process to know exactly where it is located. And then at the end of the case, the anterior portion, I released the sternal attachment of the sternocleidomastoid. And here's a clinical photograph of the posterior construct from C2 to T10. The x-rays demonstrate an excellent correction of the coronal and sagittal deformity, restoration of the sagittal parameters, and a much improved pre to post-operative radiographic result. You can see the focal kyphosis here has been corrected to lordotic alignment in the cervical spine. And clinically, he has a tremendous improvement in his appearance at 3 months and at 1 year. And the pre to post-operative outcome is outstanding. Thank you very much.
Thank you, Themi. This is two great cases. Nice to see, and that gave me also some questions that I might ask you. The first case, this is a very nice case, kyphoscoliosis in neurofibromatosis in a 21-year-old patient. Now, with that experience, usually one case gives you a lot of experience. So if the next case is coming with neurofibromatosis in the same situation, so you're starting directly up front with 3-4 rods and with BMP, what is your message out of this, or your learning point from that case?
It's funny you should mention that, because I am just in the process of getting a 3D reconstruction and 3D model of a neurofibromatosis case with a cervical thoracic junctional kyphoscoliosis. And the major challenge in these cases is frequently because of the neurofibromatosis and the expansion of the spinal canal, there are very few posterior elements available for fusion. And you just have to, from the beginning, try to get the anterior arthrodesis. So my approach different now in that I go right after the anterior arthrodesis with a posterior based VCR at that upper thoracic level, wherever the apex of the deformity is. I mean, you made very important points about looking for challenging neuroanatomy and really concave, small neuroforamina that can have tethered roots around them. But if it happens to be outside of the important roots to the hand, you can sacrifice a lot of roots in the upper thoracic spine below T2 and still get the correction that you need and get into the anterior column as needed. And I would have done a C2 UIV from the get-go if I were doing that case all over again. And as you showed, getting triple fixation in C2 is critical. Not always is there very good pedicles to do pedicle screws at C2. So if you have to settle for some pars screws, you can make them as long as possible by starting very caudal and then aiming cephalad towards the end plate. But invariably, the laminar screw does help with gaining extra fixation. I've only had one patient fail that type of fixation, and there weren't good pedicles. So there were bilateral pars screws, and the patient was severely osteoporotic and had a history of cancer. So she couldn't go on anabolic agents to build up her bone preoperatively. But otherwise, I have not had failures with the triple fixation at C2.
Very, very nice point. And it gives me to the other point. In the first surgery, the patient came with incomplete spinal cord injury, and you corrected him with the posterior cantilever technique. So you extended him, but he improved nicely after the first surgery from a neurologic point. Is it right?
That's correct. And part of it was, giving time for the cord to recover from the original resection. But I think the other part of it was stabilizing this now unstable segment where there was still some stenosis around the cord and maybe some instability that was continuing the insult to the cord. So you got to rest it by creating stability in the construct. So part of it was kyphosis correction, part of it was giving time for the cord to recover, and the other part was stabilization.
I think it's a very excellent point.
May I have a question, please?
Please, Professor Q from Nanjing.
Yeah, in case of a chin-on chest deformity combined with chin-on shoulder deformity, I find it's relatively easy to collect kyphosis, but it's extremely difficult to collect a neck tilting. So I'm wondering if we can do osteotomy in sitting position. So I never done it with a patient in a sitting position. So did you have this experience with sitting position?
I personally have not done sitting position corrections because they're challenging, and I feel that in the majority of the cases that I've had so far, I'm able to correct the coronal and sagittal deformity at the same time. In this particular case that I showed, it wasn't the most severe coronal deformity, it was more the sagittal deformity, and it was partially flexible. Doing the releases anteriorly at 3 levels and then removing the iliovertebral joints at the base of the cervical spine really helped to situate it exactly where it needed to go. But if the deformity is at the cervical thoracic junction and I'm choosing to do a correction at that level and I have to go posteriorly, like in a fusion mass, for example, and my preferred method is no longer to do an asymmetrical PSO, where the geometry of the upper thoracic vertebra or even C7 itself is limited in your ability to correct. It's only going to be so tall a vertebra, and a complete VCR allows you to really situate the spine where you need it to go. And so a 1 or 2 level VCR is preferable, in my opinion, to really correct both planes at the same time and maximize your correction in each plane.
Thank you. Very excellent. Daniel Wu for the last question. Thank you.
So, Themi, awesome cases. So for the neurofibromatosis, that's the only type of case where I will use traction typically intraoperatively, because usually there are flexible deformities. And I agree, the dural ectasia makes the posterior fixation really difficult. One, how do you correct the deformity? Are you doing it by traction? Are you doing it with fixation and then pulling? If you were to violate the dura, do you have any tips on how to fix it? Luckily, I've never violated the dura, but that's always my fear, that when you have dural ectasia, you got this patulous dura that's very friable.
Yeah, I think those are great points. I sometimes use the bivector traction But in a lot of cases, the deformity can be so complex that that you really need to kind of push and overcorrect in some ways. And so I'll have, you know, the ability to put the patient in a Mayfield vise and pull traction through the vise. And then at the end of the case, if I feel like I need to, after all the releases, now position the head in a certain way and maybe, you know, overcorrect a little to the left to get things balanced when the patient finally stands and walks, then I pull the Mayfield down to be, you know, at the brow level, and then while holding the head securely, usually the face, then reassemble the vise to the Mayfield. So we've done this kind of combined bivector traction with the vise and then convert, which you can also do with a halo. But I do like the control I get with the vise, and I like the pin sites, you know, where they're located. It's a little more cosmetic for most of the patients. In terms of the dural ectasia, you got to be prepared to patch those cases when they do occur. And synthetic dural grafts can go a long way towards securing and minimizing the sequelae of friable dura that's difficult to repair.
I also had the experience, great point, Femi, that you have maintained a very small shell of bone, like a floating bone, close to the dura anteriorly. You're not going to the risk of anterior leakage, which is a pain in the neck. So if you just have a floating two-level float below it, it can also sometimes be a safe way. So we have heard great cases. Thank you, Femi.